As we have seen, the glenoid cavity is both very small as well as shallow. It therefore provides very little support for the head of the humerus. Now, one way the body attempts to compensate for this is via a structure called the glenoid labrum. This is a fibrocartilage disc that surrounds the outer glenoid. It both increases the diameter of the cavity and effectively doubles its depth. This greatly helps prevent the head of the humerus slipping out of the joint. It also has a further important function. Let's take a look at that. Now, the glenoid labrum has been described as acting like a valve to create a seal around the joint alongside the joint capsule. So remember, in section 1 we talked about the concept of negative intra-articular pressure, a pressure within the joint which draws the bones together. Now think about this. Every time we are standing with our arm by our side, there is a force or a traction or external traction force which is trying to separate these bones. This negative intra-articular pressure helps prevent that. Now the interesting thing is, the more pressure or traction force we put in the arm, so for example if we're carrying a bag, the greater the negative intra-articular pressure. It actually reacts, which is a very neat design. When the labrum is torn, the valve is broken and that negative intra-articular pressure is lost. It makes the joint less stable. We will look at labral tears later and how they specifically occur, but just know for now that they will lead to greater instability of the joint. Negative intra-articular pressure is also lost when the joint is swollen, so after a recent injury or an inflammatory condition such as rheumatoid arthritis. Again, this will lead to instability of the joint. Next, we're going to look at the rotator cuff muscles and how they are strongly involved in stabilizing the joint. So, as we have seen from the design of the glenohumeral joint and by exploring its movements, it's highly mobile. What's more, there's not a great deal in the way of stability from bones and ligaments. Therefore, we depend greatly on stability from muscles. Around the shoulder, there are many, and of particular importance when it comes to stability are the rotator cuff. Let's now take a close look at those. There are 4 rotator cuff muscles, the supraspinatus here at the top, infraspinatus here at the very back of the scapula, teres minor at the lateral or outer edge, and subscapularis here at the very front of the scapula. The names of these muscles can be remembered by the mnemonic SITS, so supraspinatus, infraspinatus, teres minor, and subscapularis. You can see they all attach from the scapula to various locations around the top of the humerus and therefore can all act to help move the humerus in different directions. So supraspinatus is a key muscle for shoulder abduction. Infraspinatus and teres minor both externally rotate the shoulder. And the subscapularis, which is the antagonist to infraspinatus and teres minor, meaning it performs the opposite movement to these muscles, internally rotates the shoulder. Whilst the rotator cuff can all move the joint, their primary role is considered a stabilizing one. Together they all actively draw and compress the head of the humerus into the glenoid cavity. You can see from this image how the forces they each create help do this. This stabilizing role is important to appreciate if you really want to understand glenohumeral joint function. Just prior to when we move the shoulder, there is an activation of the rotator cuff muscles along with the biceps muscle. This can be described as a presetting of the joint before movement commences. This effectively stabilizes the joint, so the rotator cuff contract and draw the glenoid cavity and humerus more closely together. This creates a stiffness which may sound contradictory when we want to actually create movement, but without it, the joint would be less stable. As movement then takes place, the activity of the rotator cuff becomes more movement specific. So for example, in arm abduction, supraspinatus will be more active because it creates that movement. However, subscapularis, infraspinatus, and teres minor are still contracting because they help prevent the head of the humerus riding up the joint. That can compress other structures if it's not limited. Remember, muscles can destabilize a joint, so the action of supraspinatus can actually draw the head up. The other cuff muscles prevent that from taking place. The rotator cuff muscles help prevent the joint from misaligning both in an anterior or forward direction, posterior direction, superior direction, and inferior direction. The tendons actually blend with the joint capsule and therefore add a further layer of support or stability to the joint. They don't actually cover the inferior part, however. That does make the joint slightly vulnerable to a dislocation or separation in this direction, and that is actually the most common direction that the joint will normally dislocate, usually inferiorly and anteriorly. We'll look specifically at joint dislocations later. But overall, the joint is inherently unstable, and this is a common issue that you will come across in individuals again and again. Sometimes it can be difficult to spot as the individual may have various signs and symptoms. In more severe cases, the individual will report a sensation or feeling of the joint slipping out and then relocating. In even more severe cases, it can completely pop out and then they need someone to put it back in. In some individuals, they've experienced it so often they can actually do it themselves. In others, it can be more subtle. There can be a clicking or clunking, particularly with joint movement. There may be some associated pain with that, as well as weakness. Before we think about the ways that we might work with someone with glenohumeral joint instability, let's first look at how this might originate or how it might occur. For glenohumeral joint instability to occur, there has to be a disturbance or change in one or more of the following. The first is laxity or looseness in the joint capsule and/or an issue with the labrum. This situation might occur following shoulder dislocation or repetitive trauma over time, such as from a throwing sport. The next can be an imbalance of the strength or activity of the rotator cuff muscles. This can arise from poor use of the shoulder in daily life, sports participation, or incorrect training methods. A structural issue involving the bones of the joint. This could be due to the way the joint is formed from birth, so a congenital defect, or as a result of trauma such as a fracture. And lastly, an issue with the peripheral or central nervous system. For example, the nerve supply to the joint or muscles is affected in some way, causing weakness or paralysis. This might occur following a stroke if it's a central nervous system issue, or an injury or compression of the nerve root around the neck if it's a peripheral nervous system issue. So these are the reasons why instability can arise. Now, when we come to classifying glenohumeral joint instability, it can be done according to the direction it's unstable. These are anterior instability, posterior instability, inferior instability, and multi-directional instability, so a combination of the above. So when instability does occur, our job is much easier if we can understand which of the reasons above may have caused it in the first place and the direction or directions it is unstable. Our therapy can then be much more specific. So consider the individual's history and why the instability may have arisen in the first place. Now that is sometimes easier said than done, even for a medical specialist who has a high level of training and a variety of testing procedures at their disposal. So at the very best, you may only have a theory, and that's fine, as long as that theory is open to changing if things become clearer. At least if you consider why the instability has arisen, you may be able to make the therapy program more specific.